Valley Eldercare Center, Woodside Village, Top 10 Diagnosis Review. During this review, we will be discussing Valley Eldercare Center and Woodside Village Top 10 diagnoses from October 2018 through the present date. Although the top 10 diagnoses of our residents are continuously evolving, the following diagnoses are those which are reflected in the current facility assessment. The agenda for today is to review Valley Eldercare Center and Woodside Village Top 10 diagnoses and finish with a post-test that will require a 100% for a passing score. Valley Eldercare Center's top 10 diagnoses include hypertension, osteoarthritis, depression, hyperlipidemia, dementia, diabetes, anemia, GERD, acute and chronic kidney disease, and atherosclerosis. The top 10 diagnoses of Woodside Village include Alzheimer's dementia, hypertension, depression, osteoarthritis, hyperlipidemia, anxiety, diabetes, GERD, osteoporosis, and chronic kidney disease. As you can see, many of the diagnoses are similar between Valley Eldercare Center and Woodside Village. The first diagnosis we'll look at is hypertension. Hypertension is defined as a persistent systolic blood pressure of 140 or more, a diastolic blood pressure of 90 or more, and/or a current use of antihypertension medication. Age has been identified as a risk factor for hypertension, so this is something we should be monitoring in our residents. Hypertension has been called the silent killer, as it oftentimes can be asymptomatic. Some secondary symptoms of hypertension that we may see in the residents include fatigue, dizziness, palpitations, chest pain, and/or difficulty breathing. We should be monitoring the residents for orthostatic hypotension when the residents are changing positions, such as going from a lying to sitting or sitting to standing position. Residents may report feeling dizzy or lightheaded when making position changes. Make sure we're giving them extra time if these are being reported. You could try sitting them up at the side of the bed for a few minutes and then assisting them to stand or prepare for a transfer. Some tips for hypertension include following provider orders for medication administration and treatments, taking the resident's blood pressure on a routine basis, keeping in mind that everyone has their own normal blood pressure, and the goal is to achieve and maintain the goal blood pressure. When taking a blood pressure, make sure the extremity you have selected is appropriate for taking a blood pressure. For example, we don't want to take any blood pressures on extremities with dialysis fistulas or a previous mastectomy site. Using a blood pressure cuff that is too small or too large can result in readings that are falsely high or low. We can also try offering residents food and snacks low in sodium. And finally, notifying the provider of any concerns noted or reported from the resident. Osteoarthritis is the second diagnosis we will look at. Osteoarthritis is a slowly progressive, non-inflammatory disorder of the synovial joints. Osteoarthritis is not considered a normal part of aging, but increasing age is a risk factor for the development of osteoarthritis. The primary symptom of osteoarthritis is joint pain that becomes worse with use. Osteoarthritis typically affects joints on one side of the body. For example, the right hip may be affected and the left hip may not. The joints that are most frequently involved in osteoarthritis include the neck, lower back, fingers, thumbs, knees, and hips. Deformities may also occur and will be specific to the involved joint. Care is focused on managing joint pain and inflammation, preventing disability, and maintaining and improving joint function. To help care for these residents, work with the resident to determine individualized interventions for pain control. This may include heat and cold applications, massage, or stretching. Follow providers' orders for medication administration and treatments. Encourage the resident to participate in an RA program. Utilize adaptive equipment such as splints, braces, walkers, or canes to maintain proper alignment. Modify ADLs to allow for frequent rest periods. Assist in tasks that may aggravate joint pain, and notifying the provider of any concerns noted or reported from the resident. Next, we will look at depression. Depression is a mood disorder that can manifest itself in many ways. Residents may report feeling sad, tearful, hopeless, or irritable. Residents may also report alterations in their sleep pattern, such as difficulty sleeping or sleeping too much. They may also report feeling socially isolated or withdrawn. Physical changes may also occur, such as weight gain or loss, headache, pain, and feelings of fatigue despite getting adequate sleep. Depression is not a normal part of aging and oftentimes is unrecognized in older adults. Depression can arise from a variety of situations, such as learning a new diagnosis, loss of self-esteem or independence, moving into a care facility, or losing a loved one. Depression can also exacerbate medical conditions by affecting adherence to diet, exercise, or drug regimens. Tips for caring for residents with a diagnosis of depression include following provider-ordered medication and treatment regimens, getting the residents involved in favorable activities, helping the resident to set and achieve goals, monitoring the resident for increased fatigue, weight loss or gain, feeling of sadness, irritability, hopelessness, and altered sleeping patterns. Determine if a sleep or behavior log is appropriate for the resident. We may want to refer these residents to speak with a social worker, primary care physician, psychiatrist, or other mental health professional if needed. It is also important to monitor these residents for changes in mood, behavior, or suicidal ideations. Residents over the age of 75 have the second highest percentage of suicide. And also notify the provider of any concerns noted or reported from the resident. The next diagnosis we'll look at is hyperlipidemia. Hyperlipidemia is the term used when the blood has too many lipids or fats, such as cholesterol and triglycerides. Too much bad cholesterol in the blood increases fatty deposits in the arteries and can increase the risk of blockages. Care is focused on lowering bad cholesterol, increasing good cholesterol, and making lifestyle modifications to assist in lowering risk factors. Tips for caring for residents with hyperlipidemia include following provider-ordered medication and treatment regimens, helping the resident to eat a heart-healthy diet, which includes eating less saturated and trans fat, choosing skim milk instead of 2% or whole milk, and eating more fruits, vegetables, and whole grains. Encourage the resident to participate in an RA or exercise program. The combination of eating a heart-healthy diet and participating in an RA or exercise program may also help the resident to maintain a healthy weight, which can also help to improve cholesterol levels. And once again, we should be notifying the provider of any concerns noted or reported from the resident. The next diagnosis is dementia. Dementia is defined as a neurocognitive disorder characterized by dysfunction or loss of memory, orientation, attention, language, judgment, and reasoning. Dementia may also cause personality changes and behavioral concerns such as agitation, delusions, and hallucinations. It is estimated that about half of all residents living in a long-term care facility have Alzheimer's or related dementia. Depending on the underlying cause, the manifestations of dementia may be gradual or come on abruptly. Dementia related to neurological changes is more gradual and will progress over months to years. Warning signs of dementia may include memory loss that affects skills, difficulty performing familiar tasks, problems with language, disorientation to time and place, poor or decreased judgment, misplacing things, problems with abstract thinking, changes in mood, behavior, or personality, and loss of initiative. Care of a resident with a diagnosis of dementia includes maintaining functional ability for as long as possible, maintaining a safe environment, individualizing care needs and having these needs met, and maintaining dignity. Tips for caring for a resident with a diagnosis of dementia include following provider orders for medication administration and treatments, encouraging the residents to participate in ADLs and tasks as able. This may include brushing teeth, combing hair, or picking out their outfit for the day. Remember that residents may perform these tasks at a slower rate when they are performing them by themselves, and we should remain patient and supportive during the task. Residents with dementia may also display an array of behavioral changes, which could include repetitiveness, delusions, hallucinations, agitation, altered sleeping patterns, wandering, hoarding, and resisting care. Some interventions may be to offer the bathroom, assess for pain, assess the environment, and remove any residents from triggering stimulus. Use redirection techniques, distraction, or reassurance techniques. These can include taking the resident for a walk or ride in their wheelchair, providing a snack, or listening to music. And of course, notify the provider of any concerns noted or reported from the resident. The next diagnosis we will look at is diabetes. Diabetes is defined as a chronic multisystem disease characterized by abnormal insulin production, impaired insulin utilization, or both. We will review type 1 and type 2 diabetes. Type 1 diabetes occurs when the pancreas can no longer produce sufficient amounts of self-made insulin to maintain normal glucose levels. Those with type 1 diabetes will require insulin from an outside source to keep the body sustaining life. Type 2 diabetes is more common and accounts for approximately 90 to 95% of those with diabetes. The pancreas of those with type 2 diabetes usually produces some insulin. However, the body either does not produce enough or does not utilize it effectively, or both. These residents will oftentimes also require insulin from an outside source. Long-term complications associated with diabetes can have serious health effects. Diabetes has been noted to be the leading cause of adult blindness, end-stage renal disease, and non-traumatic lower limb amputations. Diabetes can also cause retinopathy, neuropathy, and cardiovascular disease. Care of the resident with a diagnosis of diabetes is focusing on helping the residents engage in behaviors to manage their diabetes, experience few or no hypoglycemia or hyperglycemia emergencies, maintain goal blood glucose levels, and prevent or minimize chronic complications related to diabetes. Tips for caring for residents with diabetes may include following provider orders for medication administration and treatments, monitoring the residents for hypoglycemia and hyperglycemia emergencies. Hypoglycemia is low blood glucose, and these residents may display symptoms such as cold, clammy skin, tremors, rapid heartbeat, irritability, reports of feeling faint or dizzy, slurred speech, or coma. Hyperglycemia is an elevated blood glucose, and these residents may report an increase in urination, increase in appetite, weakness, headache, nausea, and vomiting. Encourage the residents to make good decisions related to meal choices and snacks. Help the residents to find healthy substitutes to high-carb, high-sugar preferences. Pay extra attention to the lower extremities and feet during skin assessments to ensure there are no skin concerns, and notify the provider of any concerns noted or reported from the resident. Next, we will look at anemia. Anemia is defined as a deficiency in the number of red blood cells, the quantity or quality of hemoglobin, and/or volume of packed red blood cells. Anemia can develop from primary hematologic problems or can develop secondary related to diseases or disorders of other body systems. For the majority, anemia is related to an underlying cause such as iron deficiency, bleeding, chronic disease or inflammation, renal insufficiency, or cancers. And for some people with anemia, there is no identifiable cause. Signs and symptoms of anemia may vary depending on the underlying cause and oftentimes will go unrecognized in older adults, as the clinical manifestations may be mistaken for normal changes associated with aging or can be overlooked because of another health condition. Clinical manifestations of anemia may include pale skin and mucous membranes, confusion, fatigue, nosebleeds, and/or worsening cardiovascular and respiratory problems. Correcting the cause of anemia is the primary goal of care. Additional goals of care include maintaining normal ADLs, maintaining adequate nutrition, and developing no complications related to anemia. Acute interventions for anemia may include blood transfusions, drug therapy, and oxygen therapy. Tips for caring for residents with anemia include following provider orders for medication administration and treatments, prioritizing tasks and encouraging residents to have frequent rest periods to help with fatigue and reducing falls, assisting the residents with ADLs and tasks that exacerbate fatigue, encouraging the residents to eat foods high in iron such as green leafy vegetables, beans, and whole grains and enriched breads and cereals, and notifying the provider of any concerns noted or reported from the resident. The next diagnosis we will cover is gastroesophageal reflux disease, or GERD. GERD is caused by the reflux of stomach acid into the lower esophagus. It is approximated that 10 to 20% of the U.S. population experiences symptoms of GERD, which is heartburn or regurgitation, at least once a week, making this one of the most common upper GI problems. We should be monitoring the residents for reports of GERD. The most common symptom of GERD is heartburn, which is an intermittent burning or tight feeling beneath the lower sternum that spreads upward towards the throat. The residents may also complain of regurgitation, feelings of pain or discomfort in the abdomen spreading to the throat and jaw, or GERD-related chest pain that may be described as burning, squeezing, or radiating to the back, neck, or jaw. GERD-related chest pain may be relieved with antacids. Some tips for caring for residents with GERD include following provider orders for medication administration and treatments, helping the residents to avoid reflux-inducing foods and drinks such as fatty foods, chocolate, peppermint, alcohol, and colas and orange juice, eating small frequent meals and avoid eating within 3 hours of bedtime, keeping the resident sitting upward for 2 to 3 hours after meals and keeping the head of the bed elevated to approximately 30 degrees, and notifying the provider of any concerns noted or reported from the resident. The next diagnosis we will cover is acute and chronic kidney disease. Kidney or renal failure can be classified as acute or chronic. Acute kidney injury can range from a slight deterioration in kidney function to severe impairment and is characterized by a rapid loss in kidney function. This can develop in as little as hours to days, and acute kidney injury may be reversible. Chronic kidney disease involves progressive, irreversible loss of kidney function. Chronic kidney disease is more common than acute kidney injury and affects 1 of every 9 Americans. Chronic kidney disease is classified by stages. Stage 1 is a GFR less than or equal to 90. Stage 2 is a GFR 89 to 60. Stage 3, A and B, is a GFR 59 to 30. Stage 4 is a GFR 29 to 15. And Stage 5 is a GFR less than 15 or the resident is needing dialysis. Some tips for caring for residents with acute and chronic kidney disease include monitoring the resident's vital signs and weight on a routine basis, keeping an eye on their intake and output, especially a reduction in urine output, monitoring their mental status and orientation level, following provider orders for medication administration and treatments. If a resident is receiving a phosphorus-binding medication such as Renvela, making sure we are administering this medication with meals. And if the resident is on dialysis, we should be checking the access site for signs and symptoms of infection daily and notifying the provider of any concerns noted or reported from the resident. The next diagnosis we will look at is atherosclerosis. Atherosclerosis is derived from 2 Greek words that mean fatty mush and hard. The combination means that atherosclerosis begins as soft deposits of fat and harden with age. This is commonly referred to as hardening of the arteries. Atherosclerosis will begin from chronic damage to the lining of the blood vessels that may be caused by hypertension, hyperlipidemia, infections, or toxins. Fatty streaks then develop as lipids migrate into the smooth muscle cells. The fatty streaks are then covered with collagen that form a fibrous plaque. At this stage, the vessel is narrowed and blood flow is reduced due to the plaque buildup. The final stage in the development of atherosclerosis is the most dangerous and consists of a plaque rupture with thrombus formation. This causes further narrowing of the blood vessels or total occlusion. The appropriate management of modifiable risk factors may help to modify or slow progression of atherosclerosis. Modifiable risk factors may include taking steps to reduce and manage hypertension, taking steps to reduce elevated serum lipids, increase activity, manage weight, and attempt to reduce stress. Tips on how to care for residents with atherosclerosis include following provider orders for medication administration and treatments, monitoring blood pressure on a routine basis, helping the resident to choose heart-healthy foods and snacks. These include foods low in cholesterol and low in fat. Encourage the participation in an exercise or RA program. Help the resident to identify stressors and how to limit or avoid these areas, and notifying the provider of any concerns noted or reported from the resident. The next diagnosis we will look at is anxiety. There are many different types of anxiety disorders that impact adults. Specific types of anxiety disorders include specific phobias, social anxiety disorders, panic disorder, generalized anxiety disorder, acute stress disorder, post-traumatic stress disorder, obsessive-compulsive disorder, and anxiety disorders due to medical conditions. Anxiety can show in a variety of ways, which includes physical. Examples of this may be a pounding heart, chest pain, rapid heartbeat, shortness of breath, dizziness, headache, sweating, dry mouth, stomach pains, nausea, muscle aches and pains, and restlessness. Psychological, which can include unrealistic and/or excessive fear and worry about past and future events, mind racing, decreased concentration, irritability, impatient, feeling on edge, tiredness or sleep disturbance, and behavioral, which can include avoidance of situations, obsessive or compulsive behaviors, distress in social situations, and phobic behavior. Anxiety can vary in severity from mild uneasiness to a terrifying panic attack. Anxiety can also vary in how long it lasts, from a few minutes to years. It is mostly caused by a perceived threat in the environment. Tips for caring for residents with anxiety may include following provider orders for medication administration and treatments, listening non-judgmentally, assessing the resident for suicidal thoughts or ideations, giving reassurance and information, encouraging professional help such as talking with a primary care physician, psychiatrist, or other mental health professionals, encouraging self-help and other supportive strategies such as talking to friends, family, relaxation techniques, or exercise. The last diagnosis we will cover is osteoporosis. Osteoporosis is a chronic progressive bone disease characterized by low bone mass and deterioration of bone tissue leading to increased bone fragility. It is estimated that 1 in 2 women and 1 in 4 men over the age of 50 will sustain an osteoporosis-related fracture during their lifetime. Osteoporosis occurs most commonly in the bones of the spine, hips, and wrist. Typical early manifestations of osteoporosis include back pain or spontaneous fractures. If a resident has a vertebral fracture due to osteoporosis, they have an increased risk of having a second vertebral fracture within 1 year. Over time, vertebral fractures can cause height loss and a humped thoracic spine. Osteoporosis oftentimes goes unnoticed because it cannot be detected by standard X-ray until 25 to 40% of the calcium in the bone is lost. Care is focused on proper nutrition, calcium supplementation, exercise, and prevention of falls and fractures. Tips for caring for residents with osteoporosis include following provider orders for medication administration and treatments, encouraging the residents to choose foods and snacks high in calcium, which can include milk, yogurt, cottage cheese, ice cream, and spinach. If dietary intake of calcium is inadequate, calcium supplementation may be recommended. Encourage the resident to participate in an exercise or RA program, maintain a safe and clutter-free environment to assist in fall prevention, and notify the provider of any concerns noted or reported from the resident.